Let's join Dr. William Geiger for a discussion on challenging issues in hematology.
Yes, we're going to talk about hematology today. And you know, the whole object of what we're trying to do here for you is to give you information in a way that you can remember it. I have nothing to disclose, and our learning objectives, we're going to talk about anemia, some other varied hematologic things, but we're going to start out talking about venous thromboembolism. Venous thromboembolism is an encompassing term for both deep vein thrombosis in the legs and pulmonary embolism. And as you know, pulmonary embolism specifically is a major cause of morbidity and mortality, especially in hospitalized patients. 16%, it's estimated, of hospital deaths are attributed to pulmonary emboli, and of those, less than a third were suspected at the time of the patient's death. So this is a difficult area for us as clinicians. There are some risk factors. You were in medical school, you were taught Virchow's triad of stasis, endothelial injury, hypercoagulability. We know that there are more risk factors than that today that I've listed there for venous thromboembolism. And because this is a difficult diagnosis, we have some clinical prediction rules. And the first is Wells criteria for deep vein thrombosis in the legs. And for this, you get 1 point for each of the items that I have listed there: active cancer, paralysis, or immobilization, bedridden for 3 days. The whole list there, you can read it. And you subtract 2 points if there is an alternative diagnosis that is more clinically reasonable. And then you score it in this way. 3 or more is high probability of a DVT, 1 to 2 is moderate, and 0 is low probability. So let's try this with our first case here. A 38-year-old female presents with pain in her right calf of 3 days duration. She had a lap cholecystectomy 8 weeks ago and a cervical conization for carcinoma in situ 6 years ago with no recurrence. No one in the family has ever had a DVT. She has 2+ bilateral pitting ankle edema. Your choice of an initial diagnostic study would be A, protein C, protein S, venous compression ultrasounds, venogram, or D-dimer. Please mark your choice. Okay, we have a learning point here. D-dimer, in this particular case, would be the first test of choice. Let's talk about D-dimer a little bit. It is kind of problematic. I don't know about where you practice, but it seems like most places I've practiced recently, everybody who comes into the emergency department gets a D-dimer, a BNP, and a CT of the head, regardless of what their presenting complaint is. And it's overused, there's no question about it. D-dimer is a test that has a high sensitivity, a low specificity, therefore it's good to rule out, but not good to rule in. And the levels for this is less than 500 is normal, with some age adjustment for those over 50, as you can see here. So if you have a D-dimer that's below 500 and a low probability, a 0 score on your Wells criteria, DVT is unlikely. You can just move forward and look for other things. However, if you do the Wells criteria and you have a moderate, or high probability, skip the D-dimer. It's not good for ruling in. You want to do something which has a higher positive predictive value, which is the venous Doppler ultrasounds. They have a 94% positive predictive value. And the recommendation is that if those are negative and your clinical suspicion is high, you can repeat it the ultrasounds in 5 to 7 days. So that's how you use the Wells criteria for DVT. Should these patients be screened for malignancy? And the answer to that is yes. There is a greater risk, 1.3 times expected in the general population, for cancer in patients who develop DVT. But you don't need to do the $1 million workup, just a good history and physical, including pelvic and rectal exam, a few basic tests like CBC, liver functions, chest x-ray, stool guaiacs would be about all you need to do. Most of the time, if cancer is the cause of a clotting problem like this, it's already been diagnosed. What about screening for thrombophilia, those patients who are hypercoagulable? These are the current criteria. If a patient has their first episode of venous thromboembolism prior to age 50, those you screen. If they have a family history of venous thromboembolism, if they've had recurrent venous thromboembolism, unusual vascular beds, or have been treated with warfarin and have had skin necrosis from that, those are the risk factors, and those are the ones that you should screen. I've listed all the potential tests there. So let's move on here to a second case. A 63-year-old man presents with a history of several days of shortness of breath with exertion and pleuritic chest pain. He suffered a DVT 5 years ago. His PO2 in the emergency room was 85% on room air, heart rate's 110. He recently returned from vacationing in Japan. What is the best test for initial evaluation of this patient's symptoms? Would you do CT angiography? Would you do compression ultrasounds of the lower extremities, VQ scanning, or a D-dimer? Good. Most of you got this. You do CT angio. And diagnosis of pulmonary embolism is very tough. As already alluded to, it's often when patients die from a pulmonary embolism, we haven't suspected it. EKG, chest x-ray, you're taught all those findings in medical school. They're really not very specific at all. Even blood gas changes are not a specific test for this. So we have another clinical prediction rule. Now, don't confuse the modified Wells criteria, which is for pulmonary embolism, with the Wells criteria, which is for DVTs. Completely different point scales, different assessment scoring for this. But these are the way you score this, and greater than 6 is high probability, 2 to 6 is moderate, less than 2 is low probability for the modified Wells criteria for pulmonary embolism. This patient would have been pretty high on that as you look over the clinical scenario. D-dimer, you can use it for this, for those that have low pretest probability, as a less than 2 on the modified Wells criteria. That essentially would rule out pulmonary embolism. Now, they still say that pulmonary angiography is the gold standard, but there's a lot of morbidity and mortality, so we hardly ever use it anymore. We've almost exclusively gone to the spiral CT or the CT angiography. High sensitivity, high specificity. And if you have a low pretest probability on the modified Wells criteria and a negative CT, you've ruled out pulmonary embolism. If you have high D-dimer and you do a CT angio, you've also ruled out pulmonary embolism. If you have a patient who has renal failure or who's too big to go in the scanner, or can't get a CT scan for some other reason, you can use VQ scanning. It's still used. I haven't seen it used very much lately. And VQ scanning, if the radiologist reads it as completely normal, and actually I can count on one hand how many normal VQs I've ever seen, but if it's normal, you've ruled out a pulmonary embolism. A low probability scan plus a low clinical probability by the modified Wells, you've also excluded pulmonary embolism. If you have a high probability scan and a high Wells criteria, 6 or more, then you've ruled in a pulmonary embolus. Everything else is no man's land, and that's where, unfortunately, most of the patients land, in my experience anyhow, with this particular test. You need to do something else. Okay. Let's get into treatment a little bit, and this is where it gets a little bit dicey. A 48-year-old female presents with 3 days of left lower extremity swelling. Venous Dopplers reveal a DVT. She's stable, has no other medical problems. What would be the best initial treatment for this patient? A, low molecular weight heparin as an outpatient, hospitalization for unfractionated heparin and concurrent warfarin therapy, low molecular weight heparin and concurrent warfarin as an outpatient, or inferior vena cava filter. Please mark your answers for this. Low molecular weight heparin and concurrent warfarin as an outpatient was the right answer till a couple of weeks ago when I did these slides. And I couldn't change them for the course. So you need to know about the latest ACCP, American College of Chest Physicians guidelines. These are not even published yet. We found them on the internet. There's the link if you want it up on the screen. Sorry, this couldn't get into your handouts. I mean, it's literally just like 10 days or 2 weeks ago, I found out about this. And ACCP is now recommending the non-vitamin K antagonist oral anticoagulants, the so-called novel or new, the factor 10, and so forth, that we'll talk about in just a minute. They're recommending those as first line. They've also removed their use of compression stockings to prevent post-phlebitic syndrome. They used to recommend it. It's still in the slides that I've got for you, so you can put an X through that if you have a paper copy or whatever. They did that because there's really no good evidence that it does help prevent the post-phlebitic syndrome. And they also made some other suggestions about small pulmonary emboli and subsegmental areas of the lungs that may not need any anticoagulation at all. So these are the major changes. That first one is the biggest one, and they recommend any of the new anticoagulants. But I suspect, the board will probably either not have questions about this because this is new stuff, and being computerized, they can drop questions out, change them, or they'll tell you, according to 2012 or 2016 guidelines. I would suggest you read that little post on the web that ACC has. But according to the 2012 guidelines, low molecular weight heparin is preferred to unfractionated heparin whenever possible. There are fewer major bleeds, reduced mortality, bioavailability is better. You don't have the heparin-induced thrombocytopenia that you get with regular heparin, and lab monitoring is unnecessary. As far as should this be in the hospital or in an ambulatory setting at home, if the patient is stable and ambulatory, no risk of bleeding, no renal problems, insufficiency, and a reliable patient and a system to monitor, home health, drawing, whatever needs to be done, you can treat these patients as in an ambulatory setting. And criteria for inpatient are listed there as well. As far as unfractionated heparin, the 2012 guidelines said you could still use it. It's still acceptable. You need to monitor PTTs. Fondaparinux is also acceptable. But they make the point, and there have been questions on the exam repeatedly about this point, of bridging heparin. You start heparin as you start the low molecular weight heparin, and you maintain that bridging of both of the anticoagulants for at least 5 days and until the INR is in the range on 2 consecutive days, 24 hours apart. They also say, as far as duration of treatment for venous thromboembolism, the first 3 months is a high-risk period for these patients to develop recurrences or have pulmonary emboli. And so that's the critical time that they should be anticoagulated. And so for 3 months for provoked DVTs, where there is a cause for that, unprovoked, you might want to do it a little bit longer, and if it's recurrent, longer still. Now, for those, they don't tell you when. They leave it up to your clinical judgment. They recommend early ambulation, and then this second point is what you should scratch out about compression stockings. As far as treatment of pulmonary embolism, first thing, you've got to stabilize the patient hemodynamically. And you can treat some of these patients at home or early discharge if they're stable, low risk of bleeding, low renal insufficiency. I don't think I've seen that happen very often. Don't forget, start your anticoagulation before you get the CT scan. Don't delay with pulmonary embolism. You want to get them anticoagulated even if you suspect it. If anticoagulants are contraindicated, that's when you would consider an inferior vena cava filter. And if they're hypotensive, that's when you would be considering thrombolysis in pulmonary emboli. Now, a word about these newer anticoagulants. There are two classes, the direct thrombin inhibitor. Dabigatran is the first one, the only one that I know of that's been released. The one thing you need to remember about this, there have been some post-marketing studies showing increased bleeding, GI bleeding and otherwise, in older patients. So this may not be the best one for senior citizens who have this problem. The factor Xa inhibitors, there are 4 that are mentioned in the guidelines that all seem to be equally effective. There's not one yet preferred above the others, and you can use these. And the nice thing about these is that there's no bridging, but there are some other issues with these. I think we still need to be aware of that, even though they're now recommended as by the 2016 guidelines as first line. The cost is high. We've had insurance turn down treating patients with this. They say, oh, well, you don't need to have your labs monitored. Well, there are no labs you can monitor, so you're kind of flying blind. And there are some tests that the companies are working on, I understand, to do that. But even more worrisome, there's no antidote. Like you can give an antidote for heparin or vitamin K for warfarin. If you get a bleeding problem and they're on one of these newer anticoagulants, you just have to stop and hope they don't have a problem. Even fresh frozen plasma does not reverse the bleeding problems in these patients. There's a little more GI bleeding with aspirin and NSAIDs in these patients. And these mostly, until the latest guidelines, were used when there were complications or contraindications to warfarin or heparin. Stay tuned for more studies on this, and especially some things about labs and ways we might in the future be able to reverse these anticoagulation. Let's talk about this venous thromboembolism in pregnancy. A 28-year-old pregnant female, G3, P2, is diagnosed with a DVT in her right lower extremity. The treatment of choice for this patient would be A, a vena cava filter, B, unfractionated heparin and warfarin, low molecular weight heparin alone, or warfarin alone. Please mark your choice. Good. The answer is low molecular weight heparin alone, and we'll talk about the reasons for that. Venous thromboembolism is a significant problem in pregnancy. The risk increases 5-fold in pregnancy due to the physiological changes in pregnancy. Pulmonary embolism is one of the leading causes of morbidity and mortality in pregnant women in the United States. And here's an interesting fact to remember. 20 to 50% of pregnant women who experience a thrombotic event have an underlying thrombophilia. So you need to screen these ladies for the hypercoagulable state. And a history of thromboembolic event increases the risk 3 to 4 times of a recurrent in a subsequent pregnancy. Venous thromboembolism, antepartum, is as common as postpartum, although pulmonary embolism is more common immediately in the postpartum period. Don't forget, D-dimer is useless in pregnancy because of the changes in the physiologic changes of pregnancy and proteins and so forth. The way you diagnose a pulmonary embolism in pregnancy is a chest CT. ACOG tells us that is safe, that we should still use that. If for some reason you can't do that, they recommend a chest X-ray. And if the chest X-ray is normal, do a VQ scan. And if it's abnormal, still try to go back to a CT scan. And they weren't more specific than that. In pregnancy, heparin, low molecular weight heparin, do not cross the placental barrier, so they're safe. Unfractionated heparin is problematic in pregnancy because of dosage changes due to the binding proteins, renal clearance, etc. So low molecular weight heparin has shown to have fewer bleeding events in pregnancy, osteoporosis, as well as heparin-induced thrombocytopenia. However, the problem with low molecular weight heparin in pregnancy is its longer half-life than heparin. And so if you have a need to deliver a lady very rapidly and you have low molecular weight heparin on board, you've got a problem. Warfarin, never, ever use that in pregnancy. It crosses the placenta, harmful fetal effects. And there's not been enough study yet on these newer direct thrombin inhibitors and factor Xa to make any kind of recommendation about them. All anticoagulants are safe in breastfeeding mothers. Now, what ACOG says we should do with a woman who is being treated with low molecular weight heparin is to switch her to unfractionated heparin for the last month of her pregnancy, anticipating a delivery. Use compression stockings until anticoagulation is resumed postpartum, and stop the low molecular weight heparin, the unfractionated heparin when the woman goes into labor. Restart anticoagulation 4 to 6 hours after a vaginal delivery and 6 to 12 hours after a cesarean section. And then bridge them to warfarin postpartum for 6 weeks, 6 months. This is all from ACOG. Okay, so much for venous thromboembolism. I hope the 16 guidelines didn't confuse you too much, but just remember they've come down on the side of the newer anticoagulants. A 48-year-old female with rheumatoid arthritis presents to your office complaining of 2 months of fatigue and more recently dyspnea on exertion. Her hemoglobin is 9.2 with normocytic, normochromic indices. You order iron studies which show a low iron binding capacity, and high ferritin. The best treatment for this patient would be oxygen for her dyspnea, disease-modifying drugs for her rheumatoid arthritis, oral ferrous sulfate for her anemia, or oral B12 for her fatigue. Mark your choice here. Good. You treat the underlying disease. This patient has anemia of chronic illness. So the disease-modifying drugs for rheumatoid arthritis, B is the correct answer. When we talk about anemia, we have 2 ways of approaching it, morphologically and kinetic. In kinetic, we think about why isn't the bone marrow making enough red blood cells due to lack of substrate, suppression or disorders in the marrow, decreased trophic hormones, chronic illnesses, or why are the blood cells being destroyed? Hypersplenism, hemolysis, blood loss, whatever. Now, this is good to think this way, but actually making a clinical diagnosis, the morphologic approach helps us tie down a diagnosis a little quicker, and that is based on the red cell indices. The MCV, the cell size, the corpuscular hemoglobin, how much iron there is in the cells, the MCHC, and then RDW, the red cell distribution width. That's something that a lot of people scratch their head about. What does that number mean on the CBC? It basically tells you how wide the normal distribution curve for the blood cells in that particular sample that you drew. And the higher the number, the wider that distribution curve, which means you have more large immature cells. It's kind of a poor man's reticulocyte count. That's kind of the way I look at it. Doesn't mean you don't need to get a retic count, but that's the interpretation. Use these numbers to direct your workup. If they have big cells, macrocytosis, the MCV is high, you think about reticulocytes first, and that would also have a high RDW. You think about B12, you think about folate deficiencies, myelodysplasia, alcohol abuse, liver disease, hypothyroidism. All will give you potentially macrocytosis. Microcytic anemia, everybody thinks about iron deficiency, but there are a lot of other things that can do this. Problems with heme synthesis, such as lead, sideroblastic anemia, or problems with globin synthesis, which thalassemias have abnormal globins, certain hemoglobinopathies. And then chronic illness and inflammation can present with a microcytic hypochromic anemia as well. Typically, chronic disease presents as normocytic, normochromic, as in the case that we had. But don't forget, acute blood loss, acute hemolysis, hypersplenism can all give you a normocytic, normochromic anemia as well. A word about iron deficiency. You need to confirm this with your iron studies. And you need to ask the question, why is this patient iron deficient? Nutrition in this country is not usually a cause for that. So you think about menstrual blood loss, you think about GI blood loss. And don't just write off, oh, this lady is premenopausal, she's having heavy periods. You got to work up the GI tract. I've seen GI malignancies missed in the 40-year-old women who the clinician just thought, well, it's from the menstrual blood loss, so don't miss that. You should get a reticulocyte count in 4 or 5 days, and it should be popping up there if this really is iron deficiency anemia. A 3-year-old patient is brought to you after moving to your community. He has sickle cell disease, hemoglobin SS disease. The parents ask you whether he needs to continue taking the penicillin he's been prescribed by another physician. You would recommend stop the penicillin to avoid resistance. Take Pen V 125 daily for the rest of his life. Take Pen V 250 BID until age 5 at least. Take Pen V 250 daily until age 12. Okay, good. Most of you got this. It's C, Pen V, 250 milligrams BID until 5 at least. A quick word about sickle cell disease. It's the single most common single gene disorder in African Americans. It's diagnosed with hemoglobin electrophoresis. It's due to homozygous abnormal hemoglobin or sickle thalassemia disease can do it. And hemoglobin S is poorly soluble when there's been deoxygenation, such as in an exercise situation when someone becomes dehydrated, and then this sickle hemoglobin forms polymers and distorts the red blood cells. The clinical manifestations, obviously anemia, vaso-occlusive crises can occur anywhere, usually muscular, but these patients are also immunosuppressed because they have functional asplenia, therefore they're susceptible to pneumococcal, Haemophilus, and Salmonella infections. Aplastic crisis can result from exposure to parvo B19, which is the virus that causes Fifth's disease. And there's a lot of that goes around all the time. And that can be a problem, a major problem, life-threatening problem for patients with sickle cell disease. Acute chest syndrome is pneumonia plus an infarct, and splenic sequestration crises can cause acute anemia. For these patients, they are immunosuppressed. They need these immunizations, and they need the penicillin, as mentioned here. Over age 5 is controversial, and if there is a sickle cell treatment center in your area, you might see what is being done as standard of care in your area. Quick word about hemophilia. This is an inherited bleeding disorder, factor 8. Deficiency is hemoglobin A, hemophilia A. Hemophilia B is factor 9, or Christmas disease. These are X-linked, and therefore males are affected. These patients usually become symptomatic within the first 2 years of life, but bleeding, excessive bleeding with circumcision is not a sine qua non for this problem. These patients bleed many places. The worst place is into the joints, and that's why we want to diagnose and get these patients under treatment early so that they don't have joint destruction. TTP, thrombotic thrombocytopenic purpura. You need to know this pentad. Microangiopathic hemolytic anemia, thrombocytopenia, usually with purpura. They can have some acute renal insufficiency. They can have neurological symptoms and fever. Now, rarely do these patients have all 5 of this pentad, but you should know all of these there. If acute renal insufficiency is a major issue It is often called hemolytic uremic syndrome. If neurological symptoms are the highlight of this clinically, it's called TTP. It's kind of a spectrum disorder. We don't know what causes this. There are a number of different things. There is a protease of von Willebrand's factor that, because of an inhibitory autoantibody, can have a deficiency, the ADAMTS13, and this causes big polymers of von Willebrand's factor to be circulating around in the bloodstream, causing the microangiopathic anemia. Shiga toxin from E. coli can do it. Collagen vascular diseases, cancer, transplant patients can have it. And don't forget about the medications we give them. Plavix can do it, and other things that I've listed there. They need plasma exchange transfusion to cure them. Quick word about leukemias. To complete, acute leukemias, acute lymphoblastic leukemia, primarily is in children presenting with fever, bleeding, and musculoskeletal symptoms, hepatosplenomegaly, and lymphadenopathy. Acute myelogenous leukemia is primarily in adults. Fever, weight loss, fatigue, bleeding problems, anemia, and thrombocytopenia is the way these people present. The chronic leukemias are primarily adult problems, and most are asymptomatic. Most of the time you find them because they have an enlarged lymph node or they are found on a blood count. Chronic lymphocytic leukemia accounts for about 50%. They usually have hepatosplenomegaly and lymphadenopathy. Chronic myelogenous leukemia accounts for about 20%. And these patients, usually big spleens, gigantic spleens. These have the Philadelphia chromosome and this gene fusion and translocation. So thank you, and for the opportunity to talk to you about hematology.